All right. Well, we'll go ahead and kick it off. Want to send everybody a very warm welcome from our entire team at the Setting Scoliosis Straight Foundation. Welcome to our webinar on vertebral body tethering versus spinal fusion. It is a series of our patient-directed education webinars. And today I'm joined by an incredible faculty and moderator. Speaking of whom, my name is firstly Amir Samdani. I work at the Shriners Hospitals for Children in Philadelphia, and I'm joined by my incredible moderator, Dr. Feroz Mianji from Children's Hospital in Vancouver. We have a spectacular group of speakers, including Dr. Lawrence Haber, Michelle Marks, Dr. Stephen Hwang, Drs. Dan Hoernschemeyer, and Dr. Noelle Larson. Next slide. But really, our highlights for tonight are going to be our patient speakers. We have Diya, who's going to give her perspective on spinal fusion. And we're also very lucky to be joined by Jake, who will give his experience with vertebral body tethering. Just some housekeeping. Please remember to submit your questions through the Zoom Q&A. We will do our absolute best to get to answer as many of those questions either through the Q&A section in Zoom, or our moderators will bring those questions to the entire group. The agenda, again, you can see here, we've got a very packed agenda. We want to cover a bunch of topics and leave enough room for discussion. We will run through these items and also have our patient speakers in this agenda. A little bit about our organization. We are a nonprofit 501c3 established in 2018 with a mission to better discoveries and advanced techniques in the treatment of scoliosis in children and adolescents worldwide, with a vision to really have a future where children with scoliosis can have the ability to live healthy, happy, and productive lives. Of course, that's not possible without support from donations, including private donations, and then our support that we get from our industry partners. And to that end, we're very fortunate to be joined by John Quinn from Highridge, who's going to give us a message. Take it away, John.
Thank you, Dr. Samdani. So hopefully everybody can see my screen. So I'd like to start with a thank you to Michelle and to Setting Scoliosis Straight for the opportunity to tell you all a little bit about Highridge Medical. Our mission really is to help patients thrive. We regularly hold town halls in the office where we have our patients come in and tell their stories so that our employees really understand the difference that our products can make. Highridge is dedicated to improving treatment for scoliosis through programs that support awareness, education, and training for spine surgeons. And we also partner with a lot of the charity support groups like Curvy Girls and Higgy Bears, and we have them attend our booth at our industry workshops. And we also have our staff making some Higgy Bears for kind of team building events in the office. And we're also a very proud sponsor of the Setting Scoliosis Straight 30th anniversary event. And I hope you find this webinar valuable for you and your family. Thank you.
For that message, and thank you for the continued support over the years. Let's kick it off with Dr. Lawrence Haber, who's going to present us some long-term outcomes.
Good evening, everyone, and thank you for joining us. I'm coming at you live from New Orleans, down in New Orleans, where fall has finally gotten here, and we're really excited about it. So we're talking about long-term outcomes of fusion and VBT, and there's a lot of different ways to look at this, right? We can look at reoperation rates. We can look at the durability of correction. We can look at, for VBTs, what the rate of having to convert them to fusion or not having to convert to fusion. We can look at survey outcomes, which means things like the SRS survey to see what our patient outcomes look like. But spoiler alert, there's pretty good improvement for VBT and fusion on those SRS outcomes. So we're going to kind of skip that part a little bit. And then really long-term, what we want to know is, are we changing the natural history of the spine? So what we really worry about with fusion, especially lumbar fusions, is adjacent level disease, or areas around the spine that we didn't treat, having degenerative changes or breaking down later. So this is just an example of a patient that probably all of us would agree is treated better with VBT than fusion, that's had a VBT and then about 4 years later has a straight spine and it avoided a lumbar fusion. So So we're great at fusions, right? So what's the problem with fusions? We've had a low neurologic injury rate and infection rate. There's minimal transfusions. We really get powerful three-plane correction. There's immediate and durable improvement. It's usually about 2 to 3 days till discharge, so it's really a very brief hospital stay, and we've got decades of experience. When we look at survivorship from fusion, the 5-year survivorship or reoperation rate, if we want to call that failure rate, is about 5%. When we look at 10-year rates, it's 8 to 10%. That's really pretty phenomenal for a big operation and really sets a high bar for VBT. So what's wrong with, what's the problem with fusion? Why would we want to do anything different? Well, I used to get the question a lot, and I still do before fusion, of a patient or a parent asking me, so are you going to fix his spine? Are you going to fix my spine? And I always have to carefully explain that I'm not going to fix your spine. I'm going to make you look a heck of a lot better, but I'm going to fuse your spine, which is different, right? That area is not going to move. It's maximally invasive. We talked about the motion a little bit. We talked about worrying about degenerative changes later. Parents and kids sometimes do worry a lot about growth. In our adolescent population, that really isn't that big of an issue, so we don't worry about that too much. And just in general, in orthopedics, all things being equal, we like to be able to do things minimally invasively, and we like to do things that are physiologic, so that restore physiology. We don't fuse hips and knees anymore, right? We put in joint replacements. So this is just an example of a VBT, vertebral body tether, kind of what it looks like with the vertebral bodies and the screws and the cord. And really, we put this in on the convex side of the curve and get as much correction as we can and let it get more correction with growth. So that if this is a can, the vertebral bodies, the lid and the bottom are really where the growth plates are. And you can see this child, first post-op x-ray is down to about 16 degrees, corrects to about 9 degrees, and almost 3 years out, after a cord's actually already ruptured, is down to about 13 degrees. So I think we would all agree that that's a good outcome and probably won't need anything else down the road. So what's the downside to VBT in these long-term follow-ups? Well, we need to make sure that we get the deformity correction we want and that it's durable. It's not as predictable as it is with the fusion. It's a dynamic system. It's not a static system where we get correction and we're happy. We only have about a little more than a decade of experience, which is very different. It's definitely a safe and reproducible operation when it's done by the right surgeon with the correct patient. And by right surgeon, I mean just somebody that's experienced. Interestingly, some of the conventional worries that we have with surgeries, like infection rate, neurologic injury rate, and blood loss, are actually very low. The rates of those are low or almost none with VBT, which is kind of an interesting aside. So this is looking at VBT reoperation rates or failure rates from the early studies. So these are what we call first generation studies, so done before 2019. And you can see numbers that are big, right? In the 20s, in the first study, in the 30s and 40s for failure rate and revision rate. So way higher than that 5 to 8% that we talked about before. Then this is the MOM cohort, which is a combination of cases from Mayo, Ochsner, and Missouri. And all the way to the left in the blue bar, you see what our rates are compared to those first generation studies that I just quoted. And you can see that, for reoperation rate, it's much lower than it has been. And over half of those, it's at about 14%. And over half of those are for kids that just fully corrected and needed a cord released or were starting to overcorrect. Success rate now is close to 90%, which is better than it's been in the past. And our fusion rate is less than 2% in those 142 patients. So it's very low. And the follow-up is pretty similar between the studies, although we're on the shorter end and, of course, longer follow-ups needed. So that kind of shows you that's over 2 to 5 years that those long-term outcomes are starting to look better. Still not caught up to fusion in terms of reoperation, but at least heading in a better direction. So in conclusion, both are safe options. We certainly have more experience with fusions. We've been doing it for a long time. In general, fusions have a reoperation rate of 5 to 10% over 5 to 10 years. First generation VBT cases had a much higher reoperation rate. That has come down a lot in the second generation cases, but it's still a higher rate than fusion. And some of that is just dealing with that dynamic system. We have to decide if someone gets a tether and is fully corrected and we have to go back in to remove that cord or put in a looser cord. Is that really a complication or is that just part of treatment? Certainly with other growth modulation surgeries in limbs, that would be a normal process for us. And then long-term, lumbar spines, I think most of us would agree, are in better shape with motion. We don't know that for sure with thoracic. There's some studies that show that there may be increased degenerative changes below thoracic fusion, but there's studies that say that's not true. So that's certainly mixed, and more data is needed for that. Personally, I think probably the biggest upside to doing a thoracic VBT is that it's truly minimally invasive. So thank you and happy Halloween.
Great. Outstanding, Lawrence. Thank you very much for always a very informative talk. Always lots to learn from you, my friend. If there are any questions, please submit them in the Q&A, and I will try and bring them up forward for Lawrence to answer. But maybe I'll just kick it off. So Lawrence, you mentioned comparison between outcomes. Do you find that the definition of outcomes is changing now with the option of VBT on the line? I mean, when you're looking at comparison, do you talk to families about Cobb correction? Are you talking about reoperation? Is the reoperation in a fusion a little different to a VBT? Can you maybe walk us through some of those scenarios?
Yeah, I think outcome, when we look at fusion for so long, we've looked at how much do we reduce the Cobb angle, right? And I think we get caught on that a little bit. And, certainly that fusion, once it's done, the spine's straight, right? So we don't have to worry about it too much. I think that the question of outcomes becomes more, if you have a little bigger Cobb in a vertebral body tether, but you've maintained motion, and you could even take that to the point of if you have a little increased deformity, but you've maintained motion, is that worth it? Is that worth the trade-off? And I think that's something we still decide as surgeons, right? I think it's really important to discuss with patients ahead of time. And I'm not saying that a VBT case can't turn out with a straight spine, because much of the time they do. But there is an increased risk of that curve creeping back up a little bit compared to a fusion where you're kind of one and done.
Fantastic. Thank you very much, Lawrence. Just in the interest of time, I think we'll move on to our next speaker. Really needs no introduction. This I've considered the queen of motion, and really highlighting our understanding of motion in patients that have had fusion as well as tethers. So it really is an honor for Michelle to take the time this evening to educate us yet again on post-op motion and comparisons between VBT and fusion. Take it away, Michelle.
Thank you, Dr. Mianji. What a nice, warm introduction. I appreciate that. And thank you for the opportunity to present our work. I don't have any disclosures, but I want to thank my co-investigators for the long body of work we've been doing on this. There's really been a lot of increased interest in scoliosis post-op spinal mobility. It's really being driven by vertebral body tethering, right? Which has advantages of preserved motion with curve correction, and surgeon widespread adoption, and really fervent, excited patient Facebook groups. But we really felt it was time that we quantify these motion differences and really help educate patients in understanding when they're looking at post-op motion, what they could expect. So we received our first grant in 2020 from POSNA to look at primary thoracic curves and compare two cohorts, a VBT patient cohort and a PSF cohort. And we were looking at pre to post-op changes, as well as comparing the two cohorts at the 2 to 3 year post-op time point. And we look at motion radiographically. And how do we do that? We do radiographs at two bending spots, and then we look at the summation of the static angle between those two bends, and that gives us a total motion. It's really representative of the dynamic relative movement between the two static radiographs, and we look at that segmentally in between each vertebral level as well as regionally. So from the top of the spine to the bottom of the spine, so we can see what overall motion is doing. Also looking at just the instrumented segment, and then below, what's happening below the instrumented segment in the uninstrumented spines. So we matched our VBT patients with posterior spinal fusion patients 1-to-1 based on their pre-op curve size and their lowest instrumented vertebra, and we had 31 patients in each cohort. And what we saw pre to post-op was that curve correction was better with posterior spinal fusion, which has been shown previously. And that the pre to post-operative side bending motion loss in VBT is about 50% less than posterior spinal fusion. When we look at the two cohorts at just the 2 to 3 year time point, we see in the instrumented region that side bending motion with VBT is preserving about 13 degrees of motion. And with forward bending, you're preserving about 16 degrees, right? Because with the fusion, you're not going to see any motion in that instrumented segment. With overall spine motion, so looking at the region of the total spine, what we see is that VBT is preserving about 22 degrees in forward bending motion, but really not much difference that we're seeing in side bending motion between the two cohorts. In the distal uninstrumented region below that thoracic fusion or VBT, is that side bending motion isn't much different, but we do see increased motion with posterior spinal fusion. Now see, this is a reverse. Now we're seeing more motion with the posterior spinal fusion patients in the area that's not instrumented. And this we saw in our previous work as well. So it's maybe the spine taking up the slack from the area that's been fused to distribute it across more motion segments that still exist within the spine. So we had limitations to our study. Our cohorts weren't matched perfectly on their pre-op flexibility, which could be throwing a factor. And there's variability in these max efforts of these bend films. And we really don't know the ramifications, like Dr. Haber just mentioned, of the potential lumbar hypermobility that can exist following the fusion versus a residual deformity left after potential attempted curve correction with the VBT. But looking at spinal biomechanics, there's obviously the facet orientation in the lumbar region of the spine, and the size and the orientation of the vertebral bodies in the lumbar spine really contribute to that area of the spine, giving the body the most motion for trunk mobility. So perhaps VBT is going to have a better, more effect of motion preservation postoperatively if we look at the lumbar spine. So that's what we're doing now, and I want to kind of give you a sneak peek. We just got another grant, which is exciting, from the POSNA, again, now to study just lumbar curves, doing exactly the same thing that we did, only now we're just looking at primary lumbar curves in posterior spinal fusion compared to VBT. But we're mixing it up a little bit here because there's lots of different ways that VBT can be utilized in the lumbar spine. First, just in a selective lumbar, but also as a hybrid. And I'm sure we'll talk more about that in our webinar today, where you do a fusion in the thoracic spine, but then you have a tether in the lumbar spine, as well as bilateral tethers. So a thoracic tether and a lumbar tether. So we're trying to compare these types of tether usages in the lumbar spine with what would have been done posteriorly with a fusion. And we're comparing these at the pre to post changes, as well as the 2 to 3 year time point. So we have 4 sites participating. We have 23 patients enrolled thus far. We have a goal of 40. We're almost there. But here's a sneak peek. These are just preliminary results. Don't take them for total face value yet. But as we suspected, maybe we are going to see some motion preservation more so in the lumbar spine with VBT. It was an average of motion loss pre to post of only 12 degrees in VBT, whereas 38 in the posterior spinal fusion. And then looking at overall spinal motion, there's not much of a difference. So perhaps the unfused areas of the spine are, again, taking up the slack and keeping that motion the same. But with a hybrid, when you do a VBT in the lumbar spine, instead of fusing it, if you had a double major curve, we do see a difference in how much motion loss is happening. So just a sneak peek, we'll get more results soon. And in summary, we are on this road of navigating, understanding motion preservation. Quantifying it is important, but I think the biggest thing, biggest thing, is really to translate it to function. If you are preserving motion, what is that doing for your function, and how is that helping patients lead more active and fulfilling lives? That's all I have, but thank you so much. I really appreciate the opportunity.
Boy,
and thank you to all the patients who say yes to participating in our research studies. We can't do this without you. Really appreciative.
No, Michelle, thank you so much for a fantastic talk and for leading in this space. And like you said, a big thank you to all the patients and families, because they're really helping us help the next generation of patients for sure. Michelle, I'm just going to ask you a quick question here. So, with VBT in the thoracic, so the lumbar spine, it does seem that there's some perhaps significant differences that may arise as we go through this, but we'll see what the data shows. In the thoracic spine, there appear to be differences, but if I'm a patient, how much does that difference matter? Does it matter what kind of activity I'm doing? Or, for example, if I'm a gymnast, would it matter a whole lot? If I'm not, would it matter a whole lot? That loss of motion in some of the planes that you showed in the thoracic spine.
Yeah, I wish I had the answer to that question, Dr. Samdani, and I feel like
Yeah.
that's the next step that I was alluding to that we really need to kind of study is how does it translate to trunk strength? How does it translate to a high level gymnast being able to do a competition move, and
Yeah.
that's where we'll have to quantify and show the benefits of the motion preservation relating to function.
Perfect. No, thank you, Michelle, for leading the charge on this, and looking forward to a lot of your future articles and research.
Thank you.
All right. Next up is my incredible partner, Dr. Stephen Hwang. We were lucky enough to get him back to the Philly Shrine in 2017, and he's going to talk about tether breakages.
Great, thank you. Thank you, everybody. It's an honor to be here. I'm going to share a little bit about our knowledge and our experience with probably one of the more frustrating things we encounter, and I'm sure kind of disappointing for patients and families as well, with tether breakages. And so nothing relevant to this. We know Dan has published already in the past that about 50% of tethers, that first generation that kind of Lawrence talked about, can have breaks by 2 years. And Pat Cahill looked at this and kind of projected through the study that similarly about 50% by 3 years had breaks. People have found different factors that kind of link to it, but we're still learning a lot about this. The lumbar tethers, which we shifted a little bit more towards, we found up to 50 or even 60 sometimes have a break, although the revision rate is lower, so it's not quite as high. So ours have stayed around 15%-ish over time, but that's a little bit some of that first generation data that Lawrence talked about earlier as well. We looked at our own break data over the years, and it peaked around 2018, but that probably reflected more trend in practice. We just had more patients that underwent tethers, so the numbers went up naturally related to that. And the trend also shifted a little more towards lumbar tethers in our practice, in our hands, which kind of alludes to the hybrid procedures that Michelle just talked about as well. We're seeing more thoracic fusions with lumbar tethers. And, we looked at recently, Dr. Samdani actually presented some of our data looking at patients going to skeletal maturity. So we're following these kids basically till we felt they were kind of done growing. And we had about a 44% break rate. And that can also be very frustrating when you have a child that originally corrects. They seem to get a little bit better. And then over time, you see some breaks that happen thoracic or lumbar. That can be incredibly discouraging, obviously. So when does it happen? How does it happen? Some of it we don't have answers to yet, but it seems to be in our series at least about 3 years is when we see the mean time to break, although ranged quite widely from 11 months to over 100 months. And then how about a little over half of them happen in the 2 to 5 year mark as well. So they don't all happen early. Then 80, where they happen, a lot of them happen right at the apex or below. So we looked at where we saw these breaks, at least where we guesstimated them, but 80% happen below the apex. And it may be a reflection of how stiff the thoracic spine is above and where we're seeing a little more motion in that thoracolumbar spine. We actually recently looked at this, again, those children followed much longer. And not surprisingly, you saw initially the curve was in the 50s on average. It came down, corrected, improved a little bit with growth, and it kind of bounced up a little bit with the break. But the good news is they didn't change too much over a longer time. So we followed them further years out. The yellow bar in this case was kind of when they achieved skeletal maturity. They went up a couple degrees typically, and they kind of stabilized over time. For the lumbar curves, again, kind of where we've shifted a little bit more of the practice, where you see those yellow circles showing the breaks and a little bit loss of the correction that we had. It was more spread in terms of the timing of it. So we looked at almost 60 kids with follow through skeletal maturity, and about 70% of them had some degree of breaks, but the re-op rate is still about 15%, so a little bit lower, 15 to 20%, sorry. The timing again was kind of spread fairly evenly through a year, 6 months and later. The location was a little more evenly spread across the apex. We saw more of a break right around the apex, a little bit below, and then more of a bell curve right around that. And that might reflect just the range of motion we have in the lumbar spine. So this it's pretty equally distributed across that with the forces across the apex. It was very similar to the thoracic curves we saw. So looking at what happened after they broke, followed through skeletal maturity, we saw that same improvement where curves kind of improved, came down, corrected more with growth, and then jumped up a little bit with a break, and then kind of stabilized a little bit all around. And the yellow bar being again where they achieved skeletal maturity. Overall, when we looked at our series, the thoracic patients lost about 9 degrees after the initial break, and they kind of stabilized. A small percentage might have had another break, but then in the last follow-up, there's only about a degree of change from that initial progression. The lumbar curve is about 7 degrees of progression, and then on a mean about 14 months after, meaning kind of progressed a little bit, and then about 2 degrees at last follow-up, but there's quite a range with all of these. About 20% or so underwent revision surgery over a series, and it's a mix of different approaches depending on surgeon preference. This is just an example of that kind of lumbar curve. What we have done to try to adapt to this, and this is probably the second generation techniques that Lawrence addressed, is sometimes we double up and do a double row, is we put a second set of screws and cord to try to minimize that. And we recently looked at our own series, although much smaller, showing a lower rate, although we had much longer follow-up in the single row because we've been doing that for longer. So when you control the follow-up, the difference isn't significant yet. The numbers were about 24 versus 17%, meaning double rows had 17% at 2 years, and a single had 24. But we need more data and more patients to really study this and get a better sense of what's happening and how to mitigate that. So overall, the rate seems low with the double row, but we're still learning. And just to follow up with Lawrence's Happy Halloween, I want to leave with a quick message. Say Happy Halloween to everybody. This is a unicorn. There's only one image of Dr. Samdani dressed up for Halloween. On the left there is Charlie Brown. So thank you everybody for your time.
Love it. All right. Okay, Steve, great presentation as per usual, my friend. The first question is from Laurel, and they'd like to know, is there any data on the known causes of the breakage and frequency of the breakage? So what do you think is happening when it breaks, and what's the frequency? You gave us a little bit of that in your presentation.
Yeah, when we looked at our series, the reported literature is about 50% with a single cord at 2 years. Our follow-up through skeletal maturity is 44% for the thoracic ones through maturity, which was like 8 years later. So I think it varies a little bit. And again, as Lawrence said, our techniques have improved. We kind of modified and adapted indications a little as well. So I think that's reduced the rate even more so. I don't think we fully understand the reason. We tend to see them at the midpoint between the two lips. And whether it's motion, growth, axial kind of stretch, along with biologic factors that break it down, we don't fully understand it yet. But we're obviously many smart people are working on it.
And then a follow-up on that is, what are the symptoms when the tether breaks? What do patients need to look out for? And have you had any patients come in with a symptomatic breakage, say?
Not typically. I'd say a small percent of patients have noticed or felt like a little bit of a back pain episode that resolved after a couple of days, and they kind of correlated to maybe the break, but we don't know for sure. The vast majority we just tend to see in clinic and notice a break, and they kind of point out to them. And if it progresses, sometimes they notice maybe a little rotation, but I'd say the vast majority asymptomatic.
Excellent, outstanding, great. Thank you very much, Steve. That was superb. And now we're on to Dr. Hoernschemeyer from Missouri. Again, very prolific academic in the area of VBT, is really given a great sense of our understanding and growth. And he's going to talk about optimal indications. I think as surgeons in the VBT space, along with patients, we sometimes struggle to look at the ideal patient. And I think Dan will give us a nice overview of this. And again, he's taught us a lot in this area. So Dan, my friend, take it away.
Thank you, Feroz. Can you guys see my slides okay? Excellent. So what I want to share with you over the next 5 minutes are really just what I feel are optimal indications for vertebral body tethering. And I think when we first got started out, we had a lot of questions of the who, what, where, when, as far as VBT goes. And when I did a podcast the other night about VBT, somebody asked me, what's really changed the most about my practice? And it really has to do with the indications and how they've changed really over the last 10 years. And so I think this really is a balance between Cobb angle, skeletal maturity, and flexibility of a curve. And so when we have these younger kids with smaller curves, we're certainly talking about bracing. And when we have a more rigid, skeletally mature patient, we're certainly talking about fusion. But I think when we really try to balance a more skeletally immature patient with some flexibility and a reasonable curve magnitude, I think that's where VBT really fits into the picture. And when you kind of blend the FDA and insurance indications, it really comes down to a curve that's probably around 40 to 60 degrees. They really want to see curve flexibility for insurance approvals. And then even though we talked about Risser early on, I think there's a trend towards Sanders as far as looking at skeletal immaturity. Oops, sorry. And so when we look at things like triradiate cartilage, that really gives us a sense of peak height velocity if it's open versus closed. The Risser stage, again, we feel like that's probably a thing of the past, and Sanders is typically what we tend to focus on. Again, Risser sign has become a little less predictable than the Sanders staging. And when I'm talking to my patients, I really pull out some charts to really for them to understand. So we talk about the growth plates being open or closed with the Sanders staging, and then ideally, we like to see a Sanders stage 2, 3, 3A, or 3B when they're going through peak height velocity, and then a Sanders stage 4 when they're a little bit more on the post-peak height velocity side. And they always say, well, Dr. Dan, what does that mean? And I say, well, here's kind of the schematic of an adolescent growth spurt and what kids are going, and really understanding where their hand x-ray fits into this pre-peak height velocity or post-peak height velocity equation. And then I try to marry that with their Sanders score with their Cobb angle to really show them if they're very high risk. And when they have a lower, younger, more skeletally immature Sanders score, along with a larger curve, those are the kids we're going to start to then talk about a little bit about VBT. And how do we take this high risk of continued progression and roll that into deformity correction via growth modulation? And so here you see a kid with a 57-degree curve, the flexibility, but a Sanders stage 2. And after tethering with a lot of correction at the time of surgery, you can see this is really a peak growth modulation time. And as the curve continues to modulate over the next 2 to 3 years, we are really in control of correcting this curve. And that's where we want to be as surgeons. And we ended up releasing this child's tether. And so what's really important about growth modulation? When we looked at our patient populations, those that modulated and those that did not, we found that those that modulated had a 91% success rate versus those that did not modulate, those were 44% success rate. So 12.9 times more successful when we saw that growth modulation. And so optimal indications really are looking at a Sanders specific, Cobb angle specific patient, and really trying to outlay really what is ideal for that patient when they come to your office. So in conclusion, I think we're trying to balance skeletal maturity, curve magnitude, and curve flexibility. And I think when those things line up, that's when we have our best indications for VBT.
Dana, obviously on behalf of all of us, we really want to thank you for the work that you've done. I can tell you, you have helped us a ton with our indications and timing of surgery. So very much appreciate this. And just asking as a parent, if I had a child that had a 40-degree curvature and was in the thoracic curvature, that was in the Sanders 2, maybe getting into a Sanders 3. I mean, how much time do I have, Dan, to try to decide if I'm going to do surgery? Am I going to just try to brace this, avoid surgery? Like, how much time do you have in those stages?
Yeah, so I think when you look at a Sanders stage 3A, I think you have probably about a year or so, really, before that goes on to Sanders stage 3B or 4. And so I think I think you're really looking at the ideal time to get growth modulation. But again, at a curve of about 40 degrees, I think you really have some time as long as you have flexibility. And I don't think you have to rush in really at that moment in time.
No, that's really helpful as parents try to make the best decision for their children, that there is some time even as you're getting into that 3A range. So thanks again, Dan. Great job.
All right. Thank you.
All right. It is a real pleasure to introduce Dr. Noelle Larson. Tremendous amount of work in this space. Perhaps one of the most meaningful for surgeons, for patients, is the shared decision making. So go ahead, Noelle, educate us.
Well, great to be here tonight, Dr. Sandani, and I've learned so much already, and I hope we have ongoing conversations. I think the challenge really is like, how do we safely introduce new technology for our children? Like, we want new technology, we want new treatments, but how do we do this in a way that acknowledges our weaknesses? And I think tonight you've heard a lot of transparency, like we're still working on this procedure and trying to make it better. We also want to include what you guys think. We want to hear from the children, we want to hear from the adolescents, which we will in a few minutes, and we want to hear from parents. And then we want to provide information in a way that's useful to you so you can decide what is best for your own child. So Setting Scoliosis Straight Foundation shares these values, and so does the FDA. So Dr. Lahner, Michelle Marks, and I, and the whole team just finished a pretty large project working with the FDA to try to provide better education on this topic. Our first portion of the project was asking about what do patients care about. So we completed a survey at many of these surgeon sites. So thank you for helping us complete surveys asking about what do families care about regarding scoliosis surgery. So we asked just over 300 patients. We asked some patients that already had a tether, some patients that already had a fusion, and then other people who are trying to make that decision. And basically what we found is that on average, fusion was preferred over vertebral body tethering for most groups. And the most important drivers of this were spinal motion and appearance. For those that already had surgery, patients who had had a fusion really cared a lot about appearance in a deep, meaningful way, like this is not cosmetic, but just they wanted good correction of their scoliosis. And they also were concerned about failure rate of the device. People who had vertebral body tethering cared about motion and recovery time, not as much about correction. And thank goodness both sets of families are really happy with what they chose to have done. So that was part one. Part two of our study with the FDA was to make a shared decision aid, and we studied videotapes of patients and families from my site and other sites and contributed these and analyzed these, and then came up with a decision tool, which we piloted and now we've refined. So this is now available on the Setting Scoliosis Straight website, and it's a tool to be used between surgeons and patients to talk about the option of scoliosis versus fusion. So here it is on our website. And if you go to education, there's a click box. So basically it just goes through fusion surgery versus vertebral body tethering. It shows a picture and a cartoon of each, and there's actually a video that you can watch that kind of just describes in graphics in a cartoon of what the surgeries are. And then it just emphasizes these are both options that can correct scoliosis and can reduce pain. And then we let the child or the teenager pick, like, what do you want to hear about? And then we go through the different modules, so for fusion surgery, you get more correction. Vertebral body tethering is less predictable, and we have a little cartoon that shows this. For flexibility and motion, fusion surgery makes you a little bit stiffer, particularly fusion into your lower back or lumbar spine, whereas tether retains spinal mobility forward and back. Side to side, you lose a little bit of motion. Recovery time, this varies by surgeon. This is my center for recovery times, but usually a little faster return to sport. I clear people at 6 weeks. I think other doctors wait 3 months after tether, and then I'm usually clearing my fusion patients at 3 months as well. And then finally, risk of a second surgery. We're seeing about within 2 years, this is 2-year follow-up, 2 out of 100 people need a second surgery after fusion. The rate currently for all comers is 8 times higher for vertebral body tethering, 15% chance of a second surgery within 2 years. And then we have a big list of resources of papers if you want to get into the nitty gritty of the published information that help drive this model. So I'm hoping we can all use this together, and then as time goes by, we'll update the data that we see in the shared decision tool, and it'll be a way that everybody can kind of be on the same page about what's established and what's known about this procedure. Thanks.
Outstanding, Noelle. Thank you very much. Always learning from you. Maybe just again to start it off, can you explain to us, do you get many patients that come in wanting one procedure over the other, and then do you basically use this tool and try and explain both if you think they're candidates of both? Or is it something that patients come in and they're a surgical indication for surgery, but they're not too aware of both options? So can you just see how you use this for the patient that comes in wanting one option, and how you navigate them, and the other patient that really has no knowledge of the two surgical options that would be available for them in 2025, and how to use this tool for them?
I think if the patient is a candidate for both surgeries, for fusion and tether, I want to give the same conversation every time. And I want to start like a blank slate. So even if they come in convinced they want a fusion, or if they come in and convinced they want vertebral body tethering, I think it's nice just to start at square one. And I tell the family, you come in with a blank slate too, and let's just learn about it together. And I think it's been very helpful. Sometimes the patient and the parents have different ideas about what they'd like to do, and it's so a mechanism to kind of work through that. We've found that the amount of time that the teenager talks is 3 times longer when you use the tool compared to not using the tool. And then the overall visit takes 3 minutes longer. But if we're doing a better job, it's totally worth the extra 3 minutes. But give us feedback. I want to hear, and please reach out. We'll keep the program going because we want to hear from our 2 patient speakers tonight, which is our most important. But thanks for the chance to share.
Thanks, Noelle. Outstanding work as usual. Now on to, as Noelle suggested, and I think Dr. Simdani alluded to at the beginning, this is really probably the most special part of this program, where we learn, not simply here, but we learn from our patients. You know, their journeys through their treatment is extremely important, and it's everything that's really near and dear to all of us that treat patients and children and adolescents with scoliosis. And to kick it off, we have a talk from Diya Baldawa, and she's going to present her journey with spinal fusion surgery. So take it away.
Hi, everyone. Can everyone see my screen?
You can.
Okay. Hi, I'm super excited to be here. Thank you for that introduction. My name is Diya, and I'm 16 years old. So I have been living with scoliosis for most of my life. So today I'll just be talking you through like the major parts of my journey, starting with my diagnosis, back bracing, my spinal fusion, and then also how volunteering has helped me just really like grow and just feel better. So I was 4 years old when my general pediatrician noticed something off with my back, so she recommended I go get an x-ray. My curve was first found to be like 24 degrees, so it was just under the bracing threshold at that time. So since I was 4, we would go every 6 months just to get like a monitored x-ray. It wasn't severe. And that was up until I was 12 years old. We never thought scoliosis was a big deal because it never affected me in any sense. And then boom, like COVID hit, so we missed an appointment. So like I had my growth spurt like that same time. So my curve jumped up to 43 degrees. So then it was the doctors were like concerned. They were like, we should start bracing as soon as possible. My parents didn't want to jump to bracing right away because they thought it was like super severe, and it was never like a big deal to us before. So we tried going to a chiropractor in the beginning. I would go get adjusted. We tried that for 3 months, but we didn't see any results. So I did end up jumping to bracing. Bracing was definitely difficult. I had to wear it like 20 hours a day. It had an effect on me, how I felt about myself, but I started to get used to it. And at first, I did see like a slight difference, but I braced for about a year and a half, and at the end of it, my curve kept increasing. So surgery was finally like recommended because my curve went up to 52. So that's when we started considering surgery. Um, I had my spinal fusion when I was 13 years old during winter break. It was scary. It was definitely like it felt like a really big step. But yeah, the day of the surgery was also probably one of the scariest days of my life. I remember it pretty well, getting like going in and stuff because we've heard so much about it being like a big surgery. We've all done our research beforehand, but it was fine. Surgery lasted several hours, and then I stayed in the hospital for 3 days. Uh, and I remember on the first day they got me to sit up, so I was already kind of moving, and then the next 2 days, I was walking around, and then on the last day they wouldn't let me leave until I was able to like go up and down a flight of stairs. So I was moving enough, I guess, after surgery. And uh then when I got home, it was difficult, but I needed help like getting up and out of bed or like showering or things like that in the beginning, but things got like a lot better each day. I could see like a difference. After 3 weeks, I went back to school. Mostly, so I think I went back for half days in like the beginning, but over time again, it just kept getting better. I had to give up some activities, sports. I did swim and stuff, so I was like, this is the end of the world because I had to give that up for a few months, but over time everything got better. Uh Again, recovery did take time, like physically, mentally for me, but I'm just trying to be patient with myself. And now I am 2 years, almost 3 years post-op, and I'm back to full activity. I don't feel it in my daily life or like even remember I had the surgery. I feel really good. There's not much restriction in movement. Obviously, there is a little bit, but nothing too severe. Even my scar, as you can see in this picture, has reduced dramatically, so it's barely noticeable. Um, and yeah, just I'm proud of like looking back, I'm really proud of it, but also like looking back, it feels like such a small part of my life now. Um, so I think I came pretty far. And then finally, I think one of the best parts of my journey has been volunteering. I absolutely love hearing patient stories and like looking at the research that this organization is doing. I think it's amazing that we're trying to help more and more people with scoliosis. And I love talking to people who have had similar problems or are doing things just because it makes me feel happy that I can help. But yeah, that's it.
Wow, Diya, thank you so much for sharing your journey, and also for all that you're giving back. I can tell you for a fact you're making a huge difference in the lives of our patients. So thank you so much. Michelle, I see you've got a question.
I don't want to steal time from any patient attendees if there were other questions, but I'll go really quickly. Diya, you mentioned a little bit of motion restriction following your surgery. Do you notice any functional changes, like things that you could do before surgery that you can't do after?
Not too much. Nothing like really that affected me. Before surgery, I did do like I got into yoga and gymnastics. So there are like a few things I can still do them, but not like as like I'm not as flexible, so they don't look as cool when I do the poses. But I guess that's like the only thing that's really made a difference. And then for restrictions, like in my lower back, I do feel like there's this like constant like numb area that's just there. It hasn't really gone away, and it's just like if something hits it really hard, it like feels like tingly, but that's really the only effect I've had.
Thank
No,
you.
yeah, thank you for sharing that with us, Diya. There's, I'm sure, several patients or parents who are actually on this webinar tonight or will be watching it later and perhaps going into surgery for fusion. Any tips that you have for preparing prior to surgery? Is there anything that you'd recommend that they either look up, read, or do prior to going in?
I think for me, just like there's nothing really specifically. I did do a lot of research myself, and I know my parents did. So I think being explained like the whole process, especially from my surgeon, he explained the whole thing to me step by step. So that made me feel a lot more comfortable just because I knew everything that was going to happen. I like knowing like things before, so I think that was helpful. And then just realizing that like when you're out of it, it's not gonna be like the end of the world. Like,
Great advice that there is a finite amount of time. And I think that's great to ask questions of your surgeon and to realize that it is going to be a finite amount of time and then you'll be back to your activities. Well, Diya, thank you once again. We will move on to Jake. It gives me great pleasure to introduce Jake Ryan, who's going to share his journey with vertebral body tethering. Thank you, Jake.
Thank you so much, Dr. Sam Downey. Okay. Hi, everybody. My name is Jake Ryan. I'm 22 years old, and I'm here to share my experience with scoliosis, or my diagnosis with scoliosis, or whatever. So, in September of 2015, I was going for a routine checkup to my doctor when they checked out my back, and apparently they said, "Ooh, there's like a big little S curve right over here." I was in 7th grade, and it was like a very severe curve. So before that, there were sort of signs that something was wrong because my chest and shoulders would protrude, and I would never be able to like wear clothes in like a wearable way, if that makes any sense. So there was a lot of it wasn't like the end of the world or anything, but my parents really didn't want me to get the fusion because one, I didn't want to we're short people, so I didn't want to get my height restricted at all. Second, I wanted to be a little bit more flexible. And why we went with VBT, I was told that VBT was 8 hours and the fusion was 12 hours. So less time for complications, less accidents that could potentially occur, yada yada. And it was also important that it was the latest technology at the time. So usually, to our knowledge, the better technology. Yeah, I don't know. The only problem was that it wasn't like FDA approved yet, but we could get over that. This is me getting the bracing. So we went to Shriners Hospital and they pretty much laid out the plan for me to get VBT, and they put me on the brace for, yeah, it was about 8 months, and I had to wear it pretty much every day, like all times every day, just to make sure that my curve didn't get any worse, which was a little annoying, but you get over it after a while because you're going to be fine. You're going to be fixed. So when I eventually got the surgery, it was June 6, 2016. I was still 12 years old. I had it at Shriners Hospital in Philadelphia, and I think it went off without a hitch. I think I spent 4 days and 5 nights recovering before I was discharged, and home recovery lasted about a month. So there was a little bit of not hiccups at all, but just like pain at the hospital. But like it makes sense because it was like a massive surgery. But as soon as I got home, it was pretty much smooth sailing. It took about a month. This is me post surgery. So what happened post surgery? So basically, they had me walking around like pretty much the day after. Like it was a major surgery, but like it wasn't bad. No, like they made sure I was able to like function, I was only allowed to sleep on my back for 3 or 4 weeks, which was fine. It's interesting because I guess apparently like they cut a nerve or something when they were cutting into me. So there's a bit of like a numb area in between my waist and like the top of my leg, which might be common whenever you're getting surgery. And then the recovery process at surgery and at home, they had me get my stamina back or re-inflating my lung with a spirometer, which is basically this like oxygen tube that you would do breathing exercises into. And then after that, after that month recovering at home, I was pretty much fine. I just went on with my life. And how I'm doing now, I have like pretty much full mobility. I went through schooling with no problems. I mean, I was homeschooled, so like it didn't really affect me. I can do most physical activities like running, swimming, biking, playing the piano, no complications. I continued my career as a film and TV actor with no trouble. And this year, I actually successfully aged out of Shriners Hospital at 21 years. And now I'm very happy and I'm very grateful to Dr. Samdani and everyone at Shriners, all the nurses and staff, everybody there. They're the best. And now for some personal advice. This may or may not be like super totally relevant, but hospitals are pretty cold after surgery, so good luck. There's also, I feel like I didn't write this down, but I feel like I might have gotten like a little bit of like a sensation of sort of like a chill. I don't know, like more sensitive to colds in general or temperatures in general. I don't know if that's because of the surgery, but I remember it happened or I remember feeling like the difference after I had the surgery. For whatever surgery you get, like the first few days are going to be pretty rough, but it gets better. You just have to get through those first few days. It's fine. Home recovery is going to be it's going to be pretty rough too, but it shouldn't be as painful or anything. It's just going to be uncomfortable. So it's good to distract yourself. It's good. You need to get a hot, if you're into reading or watching TV or playing games or something, just something to get past whatever's uncomfortable for you. Now, scoliosis can sometimes be hereditary, as you know. So if you have any family members or siblings, get them checked out as well. We actually managed to prevent my younger brother, Jeremy, from having to get surgery because we caught it early. So he was put in the brace for 6 years, and funnily enough, he was fine. He got out. He was good. He dodged the draft. And now for the last piece of advice, which is probably the most important, which definitely helped me in surgery. Just keep a positive attitude. As I've said, it's going to be really rough, but you just got to thug it out. And if you can do that, then you can do anything. Thank you again for setting Scoliosis Straight Foundation for letting me share my story. And thank you again for Dr. Samdani and his wonderful team at Shriners Hospital for fixing me and turning me into a real boy. And thank you for bearing through my presentation. Okay.
Jake, that was outstanding. Absolutely outstanding. Thank you very, very much for sharing. And you're right, Dr. Samdani and his team are angels walking on earth. And you, I think, got very lucky to be involved from a surgeon that has a spectacular track record. My friend, just a quick question, and Jake, going back, were you nervous, possibly knowing that there was a higher risk of a reoperation with vertebral body tethering than a fusion? Did that kind of make you nervous, or was that any part of yours or your parents' decision making?
I'm sure my parents were nervous. I was definitely more nervous to be getting the surgery in general. But when I ended up when Dr. Samdani talked me through the whole process of VBT when I was 12, I had a lot more confidence in it. Most of my worries would go away. I felt good about it.
Good for you. Well, thank you, Jake. That was again outstanding. Both you and Diya really stole the show today. Just in closing, we have a couple of slides. I think Harvey, if you can start sharing. So first and foremost, we just wanted to acknowledge that the Setting Scoliosis Straight Foundation also has this handbook. It is free, and it's really created to help patients and families navigate their journey with scoliosis that has good information on scoliosis, its diagnosis, treatment options from bracing all the way to surgical options. And you can, of course, download a free digital version either on our website, and there is a QR code there as well. Next slide, please, Harvey. We also have a YouTube channel on which you can find educational videos. We also have helpful tip videos. We've got some of our research publications. So many of the speakers this evening who are very active and academic in this area, you'll find their publications there as well. And of course, we have patient stories and interviews and some of the frequently asked questions. And then these webinars will be recorded and feel free to see them on this YouTube channel for the Setting Scoliosis Straight Foundation. Next slide, please, Harvey. Of course, none of this could be possible without the generous support of our donors. These are free webinars. And so if you enjoyed what you heard, you learned something this evening, we would ask if you would please consider making a donation. You can certainly text us at the number there, or you can donate online at our website. And again, there is that QR code. Next slide, please, Harvey. And please visit our website. We have lots of interesting things. We have podcasts. We also have a webpage for patient stories, and we also have a page for parent stories. So I think it's very valuable because as we learn more and more, I think we've learned, and I've learned through this area, that it's not simply a surgical insult for a patient, but it's their entire surgical journey. And through this foundation, we're trying to help educate patients and surgeons and families through this journey. So please visit our website. Next slide, please, Harvey. Our future webinars. So this was our final patient education webinar for 2025. We do have 2 additional surgeon education webinars coming up. And one will be in late October, and the next one will be in mid to late November. And those are the dates and times. So the surgeons that are on this, please feel free to join us. So thank you very much for attending. Diya, Jake, again, a very special heartfelt thank you for sharing your stories, and my surgeon colleagues, as per usual, you all did an outstanding job. Please enjoy your evening and have an absolutely fantastic weekend. Thanks again, everybody.
Bye, everybody.